talk to us about interstitial lung diseases. Dr. Hilary Goldberg.
Thanks so much. I hope everyone can hear me. It's an absolute pleasure to be here today. I always look forward to these discussions. It's a little bit of a different format, and hopefully we're all getting used to this, but I still hope that this will be important educational information for you, and I would strongly recommend that you do look at the references, because obviously 30 minutes can't do justice to this topic, and there's lots of important information in the reference list that I hope you'll enjoy. So in terms of disclosures, I am a co-PI for a multi-center trial looking at pirfenidone in rheumatoid arthritis-associated interstitial lung disease. So as an overview of the next 30 minutes, I would like to talk about the presentation and evaluation of patients who have interstitial lung disease. And then, as Chris said, granulomatous lung disease, which is a very important topic, and cystic lung disease will be covered in separate lectures. Today, we will focus on the most common idiopathic interstitial pneumonias, including idiopathic pulmonary fibrosis and nonspecific interstitial pneumonia, and then talk about treatments, which is a very exciting area that has come a long way in the last 5 years. So how do patients with interstitial lung disease present to your clinic? You likely know they present much as patients with any form of lung disease do. They will complain of shortness of breath, cough, and potentially chest pain. The duration of symptoms, though, can be helpful in distinguishing patients with interstitial lung disease and distinguishing between the various forms. Patients who have ILD tend to present later. They tend to have had longer duration of symptoms. And so when you're examining these patients, it would be important to look not only for evidence of ILD, but also to look up for evidence of advanced lung disease more generally. So hypoxia, particularly on exertion, but potentially also at rest, any signs of clubbing, and any signs of RV dysfunction, pulmonary hypertension, or cor pulmonale, which some patients may have at the time that you meet them. And in terms of the history and physical exam, they are very helpful, particularly in doing an extensive evaluation of exposures and environmental factors that could be contributing to the development of ILD. But we certainly do rely on imaging quite importantly to try to distinguish the presence of ILD from other forms of lung disease, and then to distinguish the various forms of ILD from each other. So the pattern on imaging can be very important. Patients may have a reticular pattern, meaning lots of small lines, particularly at the periphery of the lung. There may be a more fine nodular pattern on CT scan, or there may be a combined reticulonodular pattern. The location of the disease is also very important. Some diseases are heterogeneous, meaning there are areas of preserved lung and areas of very diseased lung. But some forms of ILD are very homogeneous with a diffuse distribution that is also noted throughout the various compartments of the lung. The location in terms of upper lobe versus lower lobe predominance can also be helpful in distinguishing the various forms of interstitial lung disease from each other. So here's an example of a cut of a CT scan from the lower lobes, and you can see here, this is a bit of a heterogeneous pattern with more diseased lung in the subpleural space and some sparing of the lung more centrally. That may give you some idea of the type of disease you're dealing with, and you can distinguish that from this apical component that looks a little bit more ground glass-like in terms of its abnormality, has some bronchiectasis, but certainly a very different pattern from the CT we looked at immediately prior. So if a patient in your clinic is suggestive of having interstitial lung disease, you will have done an extensive history, as mentioned, talking about environmental factors, factors at the workplace, family history, and then you'll do that extensive physical exam, and you will likely obtain imaging, most likely with a CT scan. You'll also likely obtain pulmonary function testing. PFTs can be very helpful in distinguishing the type of lung disease that a patient may have. In ILD, most commonly, we will see a restrictive lung disease. So spirometry would be suggestive of restriction if there's a symmetric decrease in FEV1 and FEC. The restriction would be confirmed with lung volumes, which would show a decrease in total lung capacity. And patients may, in fact, have a decrease in their diffusion capacity. And this may be a sign of more advanced disease and architectural distortion associated with the interstitial lung disease. It is important to remember, though, that some forms of ILD may have a combination of restriction and obstruction, particularly those that are granulomatous in nature, where the airways may be substantially involved with the disease process. So you've done your history and physical exam, you've done your imaging, you've done your pulmonary function tests, you are concerned about interstitial lung disease. What about further diagnostic testing? Well, bronchoscopy has a limited role in the evaluation of interstitial lung disease. It is helpful to rule out other problems, such as infection, such as malignancy, and it can be helpful actually in the diagnosis of granulomatous disease, which you'll likely hear about later. The CD4 to CD8 ratio may be helpful in that setting, and the transbronchial biopsies themselves can be sensitive for finding granulomas, which could point you in the direction of either sarcoid or hypersensitivity pneumonitis. But in general, for other forms of interstitial lung disease, you really need a significant piece of tissue to be able to distinguish the architecture of the lung and to be able to see preserved areas of lung and diseased areas of lung, or a more diffuse process, in order to make a definitive diagnosis. Now, we'll talk about the diagnostic process in idiopathic pulmonary fibrosis in a moment. And oftentimes, a surgical lung biopsy is not necessary in that setting if the CT scan is supportive and you're in the right clinical setting. However, if you have atypical features, such as a young age, features on imaging that are not diagnostic of a particular process, or an atypical PFT pattern, you might want to think about a surgical lung biopsy, because the treatment for fibrotic lung disease is very different than that for an interstitial lung disease that's predominantly inflammatory. So here, as I mentioned, this is from a publication related to guidelines around the evaluation and diagnosis of idiopathic pulmonary fibrosis, which is the most common form of the idiopathic interstitial pneumonias. When we approach a patient who has abnormal imaging in the setting of suspected ILD, we would want to make sure that there's no identifiable cause for the ILD. If so, it is by definition not one of the idiopathic interstitial pneumonias. And then you would likely do more evaluation for that potential cause. For example, if you're worried about an autoimmune disease, you might do autoimmune serologies and have a rheumatologist evaluate the patient. And if you're able to diagnose the patient that way, you would spare them the surgery. And similarly for other non-IIP forms of disease. If you are worried about IIP, then if your imaging is probable or possible, if the imaging is probable or definitive for a particular form of IIP, then you could probably defer the surgical lung biopsy. But if your imaging is not diagnostic, if it's inconsistent with UIP and unclear as to another alternative diagnosis, that's where a surgical lung biopsy probably has its most important role. Now, I keep mentioning the IIPs and distinguishing them from other forms of interstitial lung disease. This is from, again, a guideline that was published in 2002. There has been, please note, a subsequent publication in 2011 that suggests alternative ways to categorize the diffuse parenchymal lung diseases. So this is not the most up-to-date, but I still refer to it because I really think it helps me to categorize in my mind when I see a patient with interstitial lung disease. How do I know what to even suspect for a diagnosis? How do I know what box to even start going down in terms of considering the evaluation? So certainly there may be clear associations with etiologies from the environment that could cause ILD. And we mentioned one, that would be autoimmune disease. Many autoimmune diseases are associated with pulmonary manifestations. So if you examine a patient and you're suspicious for collagen vascular disease, you would be going down that road of a known cause for ILD. Similarly, if patients are exposed to drugs like amiodarone or chemo or treatments for cancer that are known to have associations with pneumonitis, you would probably go down that road. Then looking at the pattern on imaging, does the pattern suggest a completely separate form of lung disease, such as cystic lung disease? That's an entirely different category of diffuse parenchymal lung disease, and you'll hear more about that later, but has its own approach. Similarly, does it suggest granulomatous lung disease like sarcoid or hypersensitivity? If so, you would take a different approach, potentially with a bronchoscopy if tissue is needed. Finally, if you rule out these other forms of diffuse parenchymal lung disease, you end up left with the idiopathic interstitial pneumonias. And at this point, it is reasonable to start thinking about whether the patient fits the category of IPF, in which case further diagnostics may not be mandatory, or if you worry about some other form of IIP, and then the evaluation will be unique to that particular process. I mentioned to you that there was a revised publication that suggested a different way to categorize these diseases. I'm not going to spend too much time on this, but you should read this if you're interested, because it's very helpful for different approaches to categorizing diffuse parenchymal lung disease. So you can categorize it by major forms versus rarer forms. And again, IPF is the most common and most well-known form, and is often confused with nonspecific interstitial pneumonia, so that's another major form. You have some of the smoking-related diseases like squamative interstitial pneumonia or RBILD, and then other forms. And then more rare situations of diffuse parenchymal lung disease that are seen less commonly. They also suggest that you could categorize these diseases based on their natural history. So we know that IPF is progressive and irreversible, and although we now have treatment options, these treatments do not reverse the disease, they just slow the progression. So you might take a different approach to those diseases than you would to, say, something that could be self-limited if there's a known exposure that can be eliminated, like the smoking-related lung diseases. So this is another way that you can categorize these disease processes in your mind as you approach a patient, and particularly as you approach their treatment options and monitoring. Now, what are these various other forms of the idiopathic interstitial pneumonias? Remember, we've now ruled out granulomatous disease, we've ruled out cystic lung disease, we've ruled out disease with a known cause, and we're left with the IIPs. And again, the most common is idiopathic pulmonary fibrosis. The finding on histology associated with idiopathic pulmonary fibrosis is usual interstitial pneumonia, and we'll look at this in a moment. Again, most commonly difficult to distinguish from nonspecific interstitial pneumonia, which has its own pattern on histology. Then we worry about acute interstitial pneumonitis, what used to be Hammond-Rich, which can also be seen as an acute exacerbation of an underlying interstitial lung disease. And in this case, on histology, we would see diffuse alveolar damage. And then finally, we have DIP and RBILD. Again, these are the smoking-related idiopathic interstitial pneumonias that are on a continuum because of an exposure to tobacco or other inhaled agents. All right, so now that we've talked about the approach to ILD in general and IIPs in particular, we want to look specifically at some of these more common forms of disease. So we should talk about IPF, again, because it's common and because it's been very difficult and challenging to understand the pathophysiology of IPF. And finally, I think we are beginning to wrap our minds around what causes this disease. So in the past, we had felt that IPF had an inflammatory component, but more and more information has become available in the last 10 years or more to suggest that there's very little inflammation associated with this disease at all. In terms of the pathophysiology, what is suspected is that there's an injury to the pulmonary epithelium, and rather than normal wound healing or normal healing from an injury in the lung, there is a process that's activated, and it's unclear what activates it, although we have some suspicions, that leads not only to recruitment of cytokines and chemokines that cause collagen deposition, but also to vasoactive substances that lead to the formation of wound clot in association with this disease as well. So the end product of this is, again, collagen deposition, re-epithelialization, but also a vascular component to this remodeling that can also potentially be a site for intervention, and that's being examined now. But what is this injury and what predisposes an individual to have this abnormal wound healing process in association with that injury? And that is something that is still being worked on, but more and more information is coming about. So there may be certain underlying etiologic factors, particularly genetic susceptibility, environmental exposures, autoimmunity, that predispose a particular individual to have this abnormal wound healing in the setting of the lung injury. There are various mechanisms, as we've talked about, that contribute to that injury and impaired healing process. This would involve abnormal host defense, the bronchoalveolar epithelial function, abnormal repair mechanisms, and cell senescence, all of which can contribute, if abnormally functioning, to the development of this end result of IPF. And finally, it is very important to note that this finding of IPF, this finding of UIP on histology, it's not an absolutely unique pathology. It's not an absolutely unique phenotype. And there are overlaps with various forms of lung disease, including autoimmune lung disease, childhood diseases, and other forms of disease that can manifest in this way. So it's important to understand those overlaps so that we can better understand the pathophysiology and potential treatments, and that's being examined now. I mentioned many potential environmental factors contributing. This would include a remote exposure to cigarette smoke, other environmental agents. Reflux is very controversial in the pathophysiology of IPF. And then certainly more and more genetic factors are being identified, genetic abnormalities that predispose patients to the development of idiopathic pulmonary fibrosis. We mentioned disc keratosis congenita. Some of the genetic abnormalities that are most common would be MUC5B abnormalities leading to increased permeability, and then abnormalities in TERT and TERK, which can affect ER stress and apoptosis. And I will not go through all of this in detail, but if you are interested, please look up these references because there's more and more information that's quite important in the pathophysiology of IPF. So back to the patient in your office though, you have a patient that you've done the history and physical on, you don't find any clear exposures or known causes for ILD, you do the imaging and you're concerned about IPF, the PFTs support a restrictive lung disease. How do you make the diagnosis? Well, the most recent publication on diagnostic criteria would include just 3 factors: exclusion of another known cause, as we talked about, the presence of the UIP pattern on HRCT, and or the components of the surgical lung biopsy supporting the diagnosis of IPF. So again, if you eliminate other factors in the history and physical, and you have an HRCT that's classic for IPF, you can pretty much stop there, and there's no mandate that you need to do a surgical lung biopsy. However, as we mentioned, the differential diagnosis is broad, and you want to be confident that the imaging is supportive. And this is where a multidisciplinary CPC is very important in the diagnosis of ILD in general. There are many publications that suggest that the use of a multidisciplinary CPC is helpful in getting to the proper diagnosis and treatment options. I mentioned that most commonly IPF can be hard to distinguish from NSIP, so I wanted to spend just a moment comparing and contrasting these 2 abnormalities. IPF in general tends to have a male predominance, and patients tend to present later in life, so in their 60s, their 70s, their 80s. They tend to have many, many months, if not years, of symptoms by the time they present, so it has an insidious onset. Patients, if they do undergo bronchoscopy, will show a neutrophilia with some eosinophilia on their BAL, and pathology will be predominantly fibrotic interstitial lung disease. The survival rates between these 2 diseases are also very different. In NSIP, patients may be younger. There is no male predominance. It's essentially equivalent between males and females. And this may be a bit more subacute, so patients may present with months of symptoms rather than years of symptoms. Again, the symptoms are similar in terms of cough and dyspnea, but these patients may also have more B symptoms. Their BAL would be more lymphocytic, and pathology could be fibrotic, but could also be cellular or have a mixture of inflammatory and fibrotic components. And again, the prognosis in NSIP is generally better, particularly if it's an inflammatory NSIP compared to fibrotic IPF. So what are those radiologic features that I keep referring to? In general, patients who have IPF clinically, who have UIP histologically, will have a subpleural predominant disease process, meaning that the central lungs are spared, and we're seeing the disease most often in the periphery of the lung. They also have a basilar predominance, so the upper lobes tend to be spared in general, although remember that none of these factors are uniformly consistent, and we see all forms of abnormalities in UIP. It's typically a reticular pattern, and there often is honeycombing with or without traction bronchiectasis on the imaging. So if you have all of those features and you have an absence of alternative features, no ground glass, no micronodules or cysts, no air trapping, no upper lobe predominant versus basilar predominant, then you can feel pretty comfortable with the diagnosis. If you have some of these atypical features, particularly if it's in a clinical setting that's not typical for IPF, that may be a situation where you want to think about a surgical lung biopsy. So again, here's an example of a patient who does have IPF. This is a basilar cut. It's a basilar predominant disease. There does seem to be a subpleural predominance, and some of the areas of the lungs are spared. So it's heterogeneous, as I mentioned to you before. There's abnormal lung in one area and well-preserved lung in another. That's very common for IPF. And the histology mimics the imaging. So again, you'll find diseased lung in the subpleural areas. You'll find fibrosis and architectural distortion with honeycombing. And you will see temporal and spatial heterogeneity on pathology with some normal lung interspersed with very diseased lung. And you should see a predominance of fibroblastic foci. You can see fibroblastic foci in other disease processes, but they should not be the predominant feature in those processes. So here is an example of a low power view of a patient who had UIP on biopsy. And even here, you can see that in the subpleural areas, there is significant disease of the lung with cystic change and a lot of subpleural thickening and interstitial change. And then sort of towards the middle of this image, you can see some very delicate alveoli with well-defined walls that are not thickened. That's your preserved lung, and that should make you suspicious for UIP. And here at a higher power view, you see the arrow pointing at an example of a fibroblastic focus. And there is, again, the subpleural fibrosis and thickening. NSIP, on the other hand, would look quite different in general. Here you can see a more diffuse pattern of disease, more homogeneous, with a lot of ground glass. There is certainly some bronchiectasis, but in general, this pattern is quite different from what I showed you with IPF. And then again, on histology, you can see here, for example, on panel B, you can see that the interstitium is very thickened, but it seems to have more of an inflammatory component with a lot of blue cells. You can see in panels E and F that there's very advanced diseased lung. And throughout these images, you can see that the interstitium is homogeneously thickened. There's homogeneous disease noted distributed throughout the lung. Now, any ILD can experience an acute exacerbation. It's most commonly seen in IPF, but you must remember that this can happen in various forms of ILD and has been reported as such. So in distinction to the sort of chronic progressive form of IPF, where we see development and progression of disease over years, some patients may experience some trigger, and those triggers are not always clear, but they can involve infection, they can involve GERD or aspiration or other contributors to stretch or ER stress that may trigger an acute exacerbation. An acute exacerbation develops over weeks, not years. And in distinction to IPF, which is mostly involving macrophages, fibroblasts, and myofibroblasts, in the setting of an acute exacerbation, you'll see more of a neutrophilic infiltration with a lot of airway edema. And ultimately, you'll see deposition of hyaline membranes and a diffuse alveolar damage pattern on histology. So how would you go about diagnosing an acute exacerbation? You would typically see a deterioration in a patient with IPF or another form of ILD that's less than 1 month in duration. You would not have a clear extraparenchymal cause for that deterioration, such as pneumothorax, pleural effusion, pulmonary embolus. And then you would see diffuse ground glass consolidations on the CT scan that are not explained by volume overload or cardiac failure. And then finally, if you don't see an alternative diagnosis, that would lead you to a diagnosis of an acute exacerbation. And we do know also that patients who experience acute exacerbation will have a poorer prognosis than those patients who do not experience that complication. And here you can see imaging. You can see in panels A and B, those represent the underlying disease of the patient. And in C and D, that's when the patient experiences the acute exacerbation. So on top of that background fibrosis, you're seeing lots of ground glass. And on pathology, again, in panels A and B, you can see the pink material, which is deposition of hyaline. This would be consistent with diffuse alveolar damage on the background of a pattern of interstitial lung disease. All right, so we've evaluated our patient. We've diagnosed him or her with IPF. We've excluded other causes, including NSIP. Now, what are we going to do for the patient? Well, until very recently, up until 2014, 2015, there was not much we could do. There were lots of different therapies that were explored, and unfortunately, none of them had sustained evidence of effectiveness in the setting of IPF. However, there were 3 landmark studies that were published in 2014 that were critical to understanding the best management, at least in the current time, of IPF. And although PANTHER was not a study looking at an effective therapy ultimately, it was a very, very important study that helped us to figure out that immune suppression probably was not the best management option for patients with chronic IPF without an acute exacerbation. So this was a study that looked at 3 arms in the setting of IPF: placebo, patients receiving N-acetylcysteine alone, which is an antioxidant that was felt to stabilize lung function in IPF, and those looking at receiving a combination of prednisone, azathioprine, and an N-acetylcysteine. Unfortunately, the arm that received the combination therapy had to close early because of a substantial increase in mortality. And ultimately, this led us to believe that an immune suppression approach is probably harmful in these patients. And then finally, the arm with the N-acetylcysteine did not show a statistically significant benefit in the setting of IPF. And therefore, this study was felt not to be to demonstrate efficacy with NAC. At the same time, landmark trials were published in the New England Journal of Medicine for both pirfenidone and nintedanib. Pirfenidone is an anti-inflammatory and anti-fibrotic agent that inhibits production and activation of TGF-beta. And TGF-beta is one of the critical components of the pathway towards development of IPF. There were animal studies that suggested that physiologically pirfenidone may be beneficial in this pathway. And ultimately, after a number of studies were done, it was demonstrated that pirfenidone both clinically and statistically slowed the rate of progression of disease. It also, in a composite endpoint, showed a decrease, slowing of the rate of progression of FVC and slowing of the rate of progression of limitation on walk distance and of death. And these impacts of pirfenidone have been demonstrated to be important even in patients who continue to decline in terms of their lung function while on therapy. So this was an important trial. I would suggest you look it up if you're interested in this topic. But patients who had decline in the first 6 months on therapy still saw benefit from being on pirfenidone for a subsequent 6 months. So in general, we are tending to treat patients early with antifibrotic therapy and to maintain them on antifibrotic therapy if they can tolerate it, even if they continue to decline. Similarly, nintedanib is a competitive inhibitor of FGFR. It inhibits VEGFR, PDGFR, and both alpha and beta. So it has potential impact not only on the collagen deposition and the fibroblast form of the IPF abnormality, but also on that vascular component. There was evidence in animal studies of reduced proliferation, migration, and survival of fibroblasts and potential attenuation of angiogenesis, which again, when we talked about the pathophysiology of this disease, could be important. And similarly, with 2 very large trials, it was demonstrated that a very similar slowing of decline in pulmonary function was noted in patients who were treated with nintedanib for IPF compared to placebo. In this study, they also demonstrated a delay to the time of onset of acute exacerbation in those patients who received nintedanib. I also thought it was very important to mention this study from 2019. This was a study that looked at patients with what we now call progressive fibrosing interstitial lung disease. These patients had various forms of ILD, not IPF. And some had hypersensitivity, some had autoimmune disease, and other forms of disease. And they were treated as a group, given the diagnosis of PF-ILD, and treated with nintedanib. And what was seen in this study was that those patients who received nintedanib experienced a very similar slowing of rate of decline of lung function when they were treated with nintedanib compared to placebo. This is a very interesting study because it's not looking at a particular disease type related to its own pathophysiology, but rather looking at the phenotype of these patients with various forms of ILD and noting that the group altogether did seem to respond to nintedanib. A post hoc analysis also showed that the effect was similar in the various subgroups that were included in this study. And then just to mention that we must remember that IPF has a very wide natural history. There is a subset of patients, although small, who will remain stable with IPF. There are some patients who will have very rapid progression of disease, some patients who will have a slow and predictable rate of progression, and then some patients who will be on a plateau and then suddenly experience an acute worsening. So this is why we still suggest that patients who are appropriate be evaluated for lung transplant at the time of diagnosis. Remember that the treatments do not reverse the disease and that there is a concern that the progression will not be predictable. So therefore, getting evaluated for transplant and being prepared for that possibility is helpful in the event that a patient deteriorates suddenly. So that was a whirlwind tour of ILD. And again, the summary statements would be that we want to try to confirm the diagnosis of ILD itself and its subtype. We talked a little bit about the various ways we can do that. It will most likely involve a high-resolution chest CT scan, pulmonary function, and the clinical picture, and then that will direct you as to whether further diagnostics are necessary. The PFTs are not only helpful in identifying a restrictive or mixed disease, but also in determining how advanced that patient's disease process is. It's important to consider exercise oximetry and then institute a treatment-based plan, including treatment of the specific disease, plus all of the supportive measures such as vaccines, referral to pulmonary rehab, appropriate nutrition, etc. All right, so we have time for questions. The first question would be, a 61-year-old man has a 40-pack year smoking history. He presents to his primary care physician complaining of progressive dyspnea and dry cough for the past 2 years. He has had a substantial decrease in his functional status. He has a non-productive cough, and he is a former banker. He has an oxygen saturation of 98% on room air and 97% after walking 200 yards. You note fine crackles on his exam, no evidence of volume overload, normal baseline labs. Pulmonary function tests show a reduced total lung capacity, and a CT scan shows bibasilar subpleural reticular findings without an infiltrate or lymphadenopathy. What would the most appropriate course of action be at this time? Refer for lung biopsy, as these findings represent an atypical presentation. Start 40 milligrams of prednisone. Consider referral for transplant after you've ruled out a cardiac component, or refer the patient for pulmonary rehabilitation. Our attendee response rate is going up. I think for the sake of time, I will proceed. And I do agree with the group. If I can, let's see if I can get these slides back. I see that I'm unable to advance the slides, but next slide. I don't see next slide. There we go. But I agree with the group that C would be the appropriate answer. This patient seems to have IPF. It's the right clinical setting and the right imaging, and therefore we would consider not only initiation of antifibrotic therapy, but also referral for lung transplantation. We can move on to the next question. This is a 51-year-old woman. She has a history of Raynaud's. She notes dyspnea that's developed over the past 6 months with a cough. She's having shortness of breath and decreased functional status. She's noted to have a saturation of 98% and desaturates to 92% with walking 200 yards. Also notes to have fine crackles, but she's found to have tenderness at the wrists and MCP joints. Basic labs are normal. Pulmonary function shows a reduced total lung capacity. And on CT scan, she has bibasilar subpleural reticular findings, but also diffuse ground glass. Would you refer for a lung biopsy, start prednisone, start an antifibrotic therapy, or refer for lung transplant? Okay, and I don't know if you can help me to proceed to the next slide. Thank you. So I would say that we would start prednisone. This patient's presentation is very suggestive of rheumatoid arthritis-associated ILD. That can present as NSIP. It can also present as a UIP pattern, and we have some features of both. But with all of the ground glass, there's a strong suggestion of inflammation. So I think at the start, we would give anti-inflammatory medication. If there was progression despite this, then we might consider antifibrotic therapy based on that study that I mentioned to you of progressive ILD. And with that, I will stop. Thank you so much. It was a pleasure to be here.
Hillary, terrific. Thank you so much. I learned a lot. Thank you. I think we have time for one quick question, if you would, and a quick answer. And the question is there a role for systemic steroids in the treatment of an acute exacerbation of UIP?
Thank you for asking that very controversial question, Chris. I think if you asked 5 of us in our ILD group, you would get 5 different answers. I would say that the experience is really anecdotal. There's not great literature about this, but I have certainly experienced patients who have stabilized and been able to be discharged from the hospital if they've received high-dose steroids in the setting of an acute exacerbation. And certainly if the prognosis is otherwise very poor, I would suggest you could try that. There are some studies looking at other interventions, but as yet there's no definitive therapy that's been shown to be beneficial in the setting of an acute exacerbation.
Great, thank you very much. There are some other questions. We'll come back to them in our question and answer session at the end, but this was very helpful. Thank you very much.
Thank you.